Morning, everyone. Today's class is about Epstein's anomaly. Into the history, it is named after William Epstein. He quoted concerning a very rare case of insufficiency of the tricuspid valve caused by congenital malformation. He was a 19-year-old cyanotic man with dyspnea, palpitations, jugular venous distension, and cardiomegaly. At autopsy, Epstein described an enlarged fenestrated anterior leaflet of the tricuspid valve in 1866. Posterior and septal leaflets were hypoplastic, thickened, and adherent to the right ventricle. There was also a thin and dilated atrialized portion of the right ventricle, an enlarged right atrium, and a patent foramen ovale. The eponym Epstein's disease was first suggested by Arnstein in 1927 and was later used by Yerter and Shapiro in 1937 review article that reported the 16th case and the first to be examined by both radiography and electrocardiography. These investigators commented that it would appear impossible to make the diagnosis during life. In 1955, Leo and colleagues described a patient with coexisting Wolff Parkinson White details of the course of the conductive tissue in this anomaly. Hardy and colleagues reported the first successful valvuloplasty in 1964 based on the concepts of Hunter and Lillehay. Embryological aspect. Uh, the leaflets are tensile. The leaflets and tensile apparatus of the atrioventricular valves seem to be formed by a process of delamination of the inner layers of the inlet zone of the ventricles. Delamination of the right ventricular free wall continues to the level of AV junction. In Epstein's anomaly, delamination of these leaflets may have failed to occur due to an incompletely understood mechanism. Process of delamination is incomplete and falls short of reaching the level of atrioventricular junction. Apical portions of the valve tissue fail to resorb completely. Distortion and displacement of the tricuspid valve leaflets and a part of the right ventricle becomes atrialized. Uh, So there is a spectrum of Epstein's anomaly with an infinite variability from normal to very severe. Epstein's anomaly occurs as a result of leaflets from their muscular precursors. Characteristic of the anterior leaflet that is crucial to most repairs is the presence of a free leading edge. The presence of a free leading edge increases the probability of successful and durable tricuspid repair. The origins of septal or posterior leaflets are displaced downwards into the RV. Leaflets are variably deformed, atrialization of the right ventricle, and anterior leaflet is enlarged and sail-like. Pathological anatomy of tricuspid valve. Origin of the tricuspid valve from atrioventricular ring and its caudal attachments are malpositioned. Leaflets are malformed, dysplastic, thickened and distorted, enlarged or reduced in size. Septal leaflet is always and anterior leaflet is seldom effective. Septal and posterior leaflets are displaced. Maximal displacement is usually at the commissure. There are three pictures here depicting variations in Epstein. So the top one is a normal tricuspid valve. The middle one is a tricuspid valve in right-sided Epstein's anomaly, showing displacement of posterior and septal leaflet. Maximum displacement is at the crux of the posterior and septal leaflets. The bottom one is a tricuspid valve. In left-sided Epstein's anomaly, the displacement is similar to that seen in right. Pathological anatomy of right ventricle. Proximal portion of the right ventricle is atrialized in one fourth of the heart's dilated. And three, it moves paradoxically during systole. Electrical potentials are ventricular, but pressure is atrial. Distal part of the RV is smaller than normal RV is dilated. Functional portion is infundibulum and trabeculated apex and portion beneath the anterior cuff. Thinner, it has thinner wall with fewer muscles. This is an autopsy specimen of a severe Ebstein's malformation of tricuspid valve, showing marked downward displacement of shelf-like posterior leaflet with attachment to underlying free wall by numerous muscular stems. The arrows point to the tricuspid valve leaflets and the atrial portion of the right ventricle. A small functional portion of the right ventricle is in the bottom and marked dilation of the right atrium. Capital leaflet displacement, atrialization of the right ventricle, tricuspid regurgitation, then that leads to atrialized right ventricle balloons out during contraction, decreased ejection, no forward flow from the RV. Indoor right
Speak,
ventricle leads to RV
speak
dysfunction.
into your mic. Your voice is getting distorted.
So, pathophysiology, there are two pathways. First, due to the septal leaflet displacement and atrialized portion that causes atrialized portion of the right ventricle and tricuspid regurgitation. This atrialized right ventricle balloons out during contraction, decreases ejection from the right ventricle. Tricuspid regurgitation also decreases forward flow from the right ventricle. Then thinned out functional RV causes RV dysfunction, no forward flow from RV. No forward flow increases the right atrial pressure and can cause physiologic pulmonary atresia. Increased right atrial pressure leads to right to left shunt and cyanosis. Etiology. Congenital, it is a congenital disease of often uncertain cause. Some environmental factors are maternal ingestion of lithium in the first trimester, maternal benzodiazepine use, maternal exposure to varnishing substances, maternal history of previous fetal loss. Risk is higher in whites than in other races, and uh, incidence is equal in male and female. Epstein's anomaly occurs in 0.3 to 0.8% of all congenital heart diseases. 1 in 20,000 to 50,000 live births, equal male female occurrence. Mortality is in children presenting with in the neonatal period is 30 to 50%. Mortality at all ages is 12 to 12.5%. Associated defects commonly associated with ASD or PFO, VSD or AV canal defect, pulmonary stenosis or atresia in 20 to 25%, and Wolff Parkinson White syndrome. Other syndromes are Downs Marfan and Noonan syndrome. Presentation at various stages of life. Fetal life diagnosed incidentally by echocardiography. Neonatal life and infancy presenting symptoms are cyanosis and severe heart failure. These symptoms improve as pulmonary vascular resistance decreases. Adult life presents as fatigue, as exertional dyspnea, cyanosis, tricuspid regurgitation, and/or heart failure, palpitations, arrhythmias are common. Neonatal congestive heart failure due to tricuspid regurgitation and RV dysfunction. Cyanosis, decreased pulmonary blood flow due to right to left shunt through ASD or PFO. Increased pulmonary vascular resistance in the neonatal period compounds this problem. Late presentation cyanosis due to right to left shunt at atrial level presents as fatigue and dyspnea secondary to RV failure and decreased LV ejection fraction. Palpitations and sudden cardiac death can occur. Incidental murmur can be detected. Paradoxical embolism can occur in some patients. Cyanosis. Cyanosis is common right to left shunt at the atrial level and or are severe heart failure. It is transient in neonatal life with recurrence in adult life. May appear from the first time for the first time in adult life. Transient appearance or worsening of cyanosis in adult life due to paroxysmal arrhythmias can occur. Once apparent, it progressively worsens. Fatigue and dyspnea. Poor cardiac output secondary to right ventricular failure and decreased left ventricular ejection fraction. Palpitations and sudden cardiac death. SVTs are seen in one third of patients. And fatal ventricular arrhythmias can occur due to accessory pathways. Arrhythmias due to right atrial enlargement and high prevalence of accessory pathways. 30 to 50% patients have evidence of secondary to atrialized RV tissue. Mapping and ablation are difficult. Atrial dilatation disrupts anatomic landmarks. Accessory pathways are often multiple. Electrophysiological studies, uh, 20 to 30% have accessory pathways. 5 to 25% have evidence of pre-excitation on the surface ECG. Right-sided pathways are more common. 50% of the patients have multiple pathways. Uh, Guided ablative therapy can be undertaken. Prenatal difficult to diagnose prenatally. Fetal presentation is variable. Possible features include cardiomegaly, right atrial enlargement, tricuspid regurgitation or dysplasia, arrhythmias or fetal hydrops. Prognosis for the fetus diagnosed in utero with significant tricuspid valve disease is very poor, 20% survival. Uh, Progressive right heart dilatation, cardiac failure, lung hypoplasia, pulmonary stenosis, or atresia can occur. Prognosis and management. Prenatal prognosis could be significantly influenced by the ability of foramen ovale to decompress right atrium. Arrhythmia due to extreme dilatation of the RA might be a sudden cause might be a cause of sudden intrauterine death. Ebstein's anomaly without cardiac failure or hydrops is an indication. Vaginal delivery can be undertaken. Otherwise, C-section is recommended. Physical examination, cyanosis and clubbing, varying degrees of cyanosis at various times in life, and transient worsening with arrhythmias. Precordial asymmetry, usually the left parasternal prominence and occasionally right parasternal prominence. Absent left parasternal right ventricular lift is an important negative sign. Jugular venous pulse may be normal. Large A and B waves late in course of the disease with the development of right ventricular failure. Arterial pulse is usually normal. Sometimes you can have diminished volume. Heart sounds. First heart sound is widely split with loud tricuspid component. Mitral component may be soft or absent in the presence of prolonged PR interval. Second heart sound is usually normal or widely split when the pulmonary component is delayed due to right bundle branch block. Additional heart sounds and murmurs. Third and fourth heart sounds commonly present even in the absence of congestive heart failure. Summation of third and fourth heart sounds, especially with prolonged PR interval, can mimic an early diastolic murmur. Holosystolic murmur of tricuspid regurgitation at the lower left parasternal area and sometimes at the apex can be heard. Murmur intensity and duration increase during inspiration. Valid ECG rhythm, usually sinus rhythm with findings intermittent SVT, paroxysmal SVT, atrial flutter, atrial fibrillation. fibrillation or abnormal P waves consistent with right atrial enlargement called Himalayan P waves. PR interval most commonly prolonged may be normal or short in patients with WPW syndrome. First degree AV block is frequent, occurring in up to 40% of patients. QRS complex may show right bundle branch block. X-ray is a PA view X-ray with, and later one is a diagram showing. So this X-ray shows extreme cardiomegaly involving primarily the RA and diminished pulmonary vascularity. The diagram shows the size of the RA compared to rest of the chambers. Echocardiogram is a standard for diagnosis of paradoxical septal motion, dilated right ventricle, delayed closure of tricuspid valve leaflets more than 65 milliseconds after mitral valve closure. Two-dimensional echocardiogram, apical displacement of the septal leaflet greater than 8 millimeters per meter square of body surface area, abnormalities in morphology and septal attachment of septal and anterior tricuspid leaflets, eccentric leaflet coaptation, dilated right atrium, dilated right ventricle with decreased contractile performance, various left heart structural abnormalities. So the diagram at the corner shows subcostal view, apical four chamber view with dilated RA and atrialized right ventricle. The other one is uh, this is a subcostal view showing anterior leaflet, sorry, right atrium and right ventricle with atrialized portion of the right. Assessment of severity and surgical options. Functional right ventricular area less than 35% of the total right ventricular area or an atrialized to functional right ventricular ratio greater than 0.5 is associated with unfavorable prognosis.
On echocardiogram slide. Put the next slide on.
Okay, sir. Yeah.
Yeah.
So, functional right ventricular size, degree of septal leaflet displacement, amount of leaflet tethering, magnitude of leaflet deformity and dysplasia, aneurysmal dilatation of right ventricular outflow tract, right ventricular outflow tract to aortic root ratio more than 2.1 to more than 2 on parasternal short axis view, then moderate to severe tricuspid regurgitation. Keller-Mayer index. Keller-Mayer et al. Described an echocardiographic grading score for neonates with Ebstein's anomaly, the Great Ormond Street echocardiography score with grades 1 to 4. The ratio of the combined area of RA and atrialized RV is compared to the functional and left heart, that is LA plus LV. This classification is particularly helpful with neonatal Ebstein's anomaly. Grade 1 is ratio less than 0.5. Grade 2, 0.5 to 0.99. Grade 3 is 1.0 to 1.49. Grade 4 is more than 1.5. Significance of ghost score is grade 1 mortality is 8%. In grade 2, the mortality is 9%. In grade 3, acyanotic patients, mortality in the neonatal period is 10% and later is 45%. In grade 3, cyanotic patients, mortality is almost 100% and grade 4, mortality is 100%. Cardiac MRI. Cardiac MRI imaging has emerged as another tool for evaluation of Epstein's anomaly. It provides quantitative measurement of right atrial and ventricular size and systolic function, even in the presence of significant distortion of right ventricular anatomy. Cardiac cardiac catheterization no longer required to make or confirm the diagnosis. The most diagnostic characteristic is typical atrial pressure and ventricular intracardiac ECG in the atrialized portion of the RV. Elevated right atrial pressures and right to left shunting with systemic desaturation and elevated right ventricular and diastolic pressures. Natural history. It is not uncommon for Epstein's anomaly to be undiagnosed until adulthood. However, late diagnosis is associated with reduced survival. The mean age of diagnosis in a study of the natural history of 72 unoperated patients was 23.9 plus or minus 10 years. In this group of patients, arrhythmias were the most common clinical presentation, seen in 51%. Estimated cumulative overall survival rates were 89%, 76, 53, and 41% at 1, 10, 15, and 20 years of follow-up respectively. Natural history again. Predictors of cardiac related death on univariate analysis included cardiothoracic ratio of greater than 0.65, increased severity of tricuspid displacement on echocardiography, New York Heart Association class 3 or class 4 symptoms, cyanosis, severe tricuspid regurgitation, yeah. In a multivariate model, younger age at diagnosis, male sex, cardiothoracic ratio of more than 0.65, and severity of tricuspid leaflet displacement on echocardiography were predictors of late cardiac mortality. Management includes severity assessment, guidelines or indications for intervention, medical management, surgical management, post-operative functional status. Carpentier's classification. In 1988, Carpentier et al. Proposed the following classification of Epstein's anomaly. Type A is the volume of the true RV is adequate. Type B, large atrialized component of the RV exists, but the anterior leaflet of the tricuspid moves freely. Type C, the anterior leaflet is severely restricted in its movement and may cause significant obstruction to RVOT. Type D almost completely except for a small infundibular component. So the image the images show type A to type D. The first one is type A. Uh, type A has both mobility and contractility. Type B has a large atrialized portion of the right ventricle. It has the anterior leaflet is mobile and contractility is also present. In type C, mobility of anterior leaflet is restricted, but contractile portion is there. Type D is the most severe form of Epstein's with only a small infundibular portion of the RV left. Indications for intervention. So class 1, the following situations warrant intervention. Limited exercise capacity, NYHA class greater than level 2, level of evidence B. Increasing heart size. Cardiothoracic ratio greater than 65 is a class 1 indication with level of evidence B. Important cyanosis. Resting oxygen saturation less than 90%. Again, class 1 indication, level of evidence is B. Severe tricuspid regurgitation with symptoms, also level of evidence B. Transient ischemic attacks or stroke, level of evidence B. Patients who require operation for Epstein's anomaly should be operated on by congenital heart surgeons who have substantial specific experience and success with this operation. Every effort should be made to preserve the native tricuspid valve, level of evidence C. Neonatal Epstein's Neonatal Epstein's anomaly is associated with poor prognosis, reported survival only 68%. Indications for surgery, heart failure, or profound cyanosis. Initial management includes prostaglandin infusion, placement of umbilical catheters, Initiation of mechanical ventilation, minimum possible airway pressure should be maintained. Tidal volumes of 10 to 15 ml per kg to overcome atelectasis. Management of pulmonary hypertension and management of congestive heart failure. So, this is an article presented, published by Dr. Christopher J. Nott Craig and at others in World Journal of Pediatric and Congenital Heart Surgery regarding surgical decision making in neonatal Ebstein's anomaly, giving an algorithmic approach. So this is the algorithm. At birth, patients who are stable require supplemental oxygen observation for adequate cardiac output, plus or minus prostaglandin infusion. As pulmonary vascular resistance decreases, remove support and follow closely. In critically unstable patients, intubate, uh, paralyze, and start inotropic supports, inhale nitric oxide and prostaglandins. If patient has functional pulmonary atresia, stop prostaglandins, improve as pulmonary vascular resistance decreases, remove supports and follow closely. If on stopping prostaglandins, if the patient has continued severe cyanosis, if there is pulmonary atresia, that is anatomic pulmonary atresia, it is an indication for surgery. Anatomic pulmonary atresia, diminutive RV with mild TR, uh, PT shunt plus reduction atrioplasty is recommended. In anatomic pulmonary atresia with moderate to severe TR and small right ventricle, stance palliation is recommended. And anatomic pulmonary atresia with adequate right ventricle, biventricular repair with RV to PA conduit is recommended. In functional pulmonary atresia, if normal LV size is there and mild TR, inhaled nitric oxide plus or minus sildenafil, small BT shunt plus early bidirectional glen is recommended. In moderate to severe TR, complete biventricular repair. In critically unstable patient, emergent ligation of main pulmonary artery followed by stance palliation, or BT shunt or hybrid procedure. In small RV size, transplant is recommended. Surgical options in neonate repair, single ventricle pathway with right ventricular exclusion, that is stance approach, or cardiac transplantation. Biventricular repair, not Craig approach. Tricuspid valve is repaired and the atrial septum is partially closed. This repair is typically a monocuspid type based on a satisfactory anterior leaflet. Routine right atrial reduction is important to reduce the size of markedly enlarged heart to allow room for the lungs. Although early mortality is high, about 25%, the intermediate outcome appears to be promising. Survival to hospital dismissal of 34%, no late mortality. So this picture demonstrates biventricular repair of neonatal Epstein's by not Craig's approach. The first picture A shows partition of tricuspid orifice into two openings by approximation of the annuloplasty stitch. Once the valve is judged based on competency, the caudal orifice is closed and thereby placating the atrial portion of the RV. Creation of a monocuspid valve by takedown of the anterior leaflet from the annulus, fenestrating it and augmenting it with a pericardial patch. The fourth image shows ASD closed with a fenestrated patch and an annuloplasty stitch placed with one pledgeted end in the coronary sinus and the other pledgeted end on the commissure between anterior and posterior leaflets. Next. Reduction right atrioplasty is another one. Tricuspid reduction right atrioplasty, tricuspid repair, reduction annuloplasty, construction of monoleaflet tricuspid valve, augmentation of the functional leaflet if deficient, ASD closure. These are the steps in Not Craig's approach. Creation of functional RVOT using a small patch. RVOT diameter in neonates is 7 to 8 mm. Pulmonary insufficiency is very poorly tolerated. Patients with suboptimal tricuspid repair, RVOT should be repaired with a valve conduit. Right ventricular exclusion by Starnes approach. Starnes et al. Pioneered the right ventricular exclusion approach, which involves fenestrated patch closure of tricuspid valve orifice, enlarging the interatrial communication, right atrial raising a systemic to pulmonary artery shunt. It is particularly useful when there is anatomic RVOT obstruction. Right ventricular decompression is required as it passively fills from Thebesian venous drainage. This is usually accomplished with a 4 to 5 mm punch fenestration in the tricuspid patch. Modified stance approach, total ventricular exclusion. Sano et al. Modified stance single ventricular approach by performing a total right ventricular exclusion in which the free wall of the RV is resected and closed primarily with a polytetrafluoroethylene patch. This is right ventricular plication, which may improve left ventricular filling and provide adequate decompression to the lungs and LV. Management in children and adults. Medical management includes bacterial endocarditis prophylaxis, may be required in the presence of prosthetic materials or patches that were used for repair. In mild Ebstein's anomaly with near normal heart size and in the absence of arrhythmias, athletes can participate in all sports. However, in severe Ebstein's anomaly, active it has been optimally repaired with near normal heart size and no arrhythmias. Indications for surgery. Presence of symptoms, cyanosis, paradoxical embolization, patients who have decreased exercise performance, progressive increase in cardiothoracic ratio, progressive right ventricular dilatation and dysfunction, onset or progression of arrhythmias, presence of New York Heart Association class 3 or 4 symptoms or significant symptoms. Principles of surgery for Ebstein's anomaly. The following principles are the goals of surgery. Closure of any intracardiac communication, tricuspid valve replacement or repair, ablation of arrhythmias, selective plication of the atrialized RV from apex to base, reduction right atrioplasty, repair of associated defects, example closure of VSD, etc. Tricuspid valve repair and ASD closure. The goal of operation is to obtain a competent tricuspid valve, preserve right ventricular contractility, and decrease the risk of late rhythm disturbances. So, Danielson repair. This repair technique was reported in 1979 and was based on the creation of monocusp valve using anterior leaflet. Repair consisted of plication of free wall of the atrialized RV, posterior tricuspid annuloplasty, and reduction atrioplasty. Modified Danielson repair modifications involve bridging of anterior papillary muscle towards the ventricular septum, which facilitates coaptation of the leading edge of the anterior leaflet with the ventricular septum. Generally, an anteroposterior tricuspid purse string or ringed annuloplasty is used, and atrialized right ventricular plication is performed selectively. This results in a tricuspid repair at the level of the functional annulus, in contrast to original repair, which brought the hinge point of the functional annulus up to the true annulus. A more recent modification includes patch augmentation of the mid-anterior leaflet with surgical delamination of attachments to the anterior and or inferior leaflets. So, this is a repair of tricuspid regurgitation in Epstein's anomaly using modified Danielson approach. So, a series of pledgeted mattress stitches are taken in the atrialized RV and then passed through the annulus. Stitches are continuous to like sorry. Stitches are passed through a carpal. Then atrial septal defect is closed by a finished pericardial patch, and plication sutures are tied over the annuloplasty ring to remodel the annulus and obliterate the atrialized portion of RV to complete the repair. Large anterior leaflet occludes the AV valve, AV orifice. Sorry. Now, this is a diagram of Mayo Clinic modification of the Danielson repair. So, the two papillary muscles arising from the free wall of the right ventricle with short caudal attachments to the leading edge of the anterior leaflet. The septal leaflet is diminutive and only a ridge tissue is present. Posterior leaflet is not well formed and is adherent to the underlying endocardium, and a small patent foramen ovale is present. In pictures B and C, we can see mattress stitches pass through the base of the papillary muscles and then with felt pledgets. This allows movement displacing the papillary muscles towards the septum. Then patent foramen ovale is closed by a direct suture. In D, posterior angle of the tricuspid orifice is closed by bridging right side of the anterior leaflet down to the septum and plicating the non-functional posterior leaflet in the process. In E, posterior annuloplasty is performed to narrow the diameter of tricuspid annulus. In F, we can see an anterior purstring annuloplasty to further done to further narrow the tricuspid annulus. This annuloplasty stitch is tied down over a 25 millimeter valve sizer in an adult to prevent tricuspid stenosis. G shows completed repair that allows anterior leaflet to function as a monoleaflet valve. Carpentier repair. In 1988, Carpentier et al. Proposed a repair that used mobilization of the anterior leaflet of the tricuspid valve. For their types B and C, temporary detachment of the anterior leaflet and adjacent part of the posterior leaflet was followed by longitudinal plication of the atrialized ventricle and adjacent right atrium, repositioning of the anterior and posterior leaflets to cover the orifice area at the normal level, and remodeling and reinforcement of the tricuspid annulus with a prosthetic ring. So, repair of Ebstein's anomaly using Carpentier's method. In A, 3/4 of the enlarged anterior leaflet and as much of the posterior leaflet are detached from the annulus. Incision is continued to the point at which the valve begins to be displaced on ventricular wall at the atrialized portion of the RV. In B, detached leaflet is everted to expose the support mechanism. There is usually caudal fusion, which may be marked in some cases. Fenestrations are made in the support mechanism to lengthen the chordae and relieve the obstruction below the leaflets. Unique aspect of this repair is placing pledgeted reinforced plication stitches in atrialized portion of the RV to create a vertical plication. Plication stitches are continued from the base of the leaflet attachment to the true annulus. Annulus is narrowed by this technique. A few stitches are placed in the floor of right atrium. Plication stitches may be woven across atrialized portion for better obliteration of this part of ventricle. D and E shows detached portion of the tricuspid leaflet is rotated clockwise to cover the tricuspid orifice beyond the plication as far toward the septum as it will reach comfortably. Leaflet is reattached to annulus by continuous suture, and repair is supported by a Carpentier's annuloplastic ring, which also remodels the shape of annulus to the tricuspid annulus by a series of mattress sutures placed at the perimeter of annulus. These stitches are most easily placed before anterior leaflet is reattached. A gap in the annuloplasty ring protects the conduction system from injury. Cone reconstruction of the tricuspid valve for Ebstein's anomaly, anatomic repair. In 1993, uh, cone repair was described by Dr. Da Silva from Brazil when the anatomy allows, as this technique is the most anatomic of all repair techniques described. Specifically, some septal leaflet should be present, which facilitates this repair technique. The cone technique represents the most anatomic repair by completion of the delamination process of tricuspid valve, providing 360 degrees of leaflet tissue around the atrioventricular junction with its hinge point at the atrioventricular groove, true annulus. So the technique is right atrial oblique right atriotomy is performed with an incision parallel to the atrioventricular groove. Left heart is vented via a catheter inserted across the patent foramen ovale or atrial septal defect. Stay sutures are placed in the true tricuspid annulus at approximately 10 o'clock and 2 o'clock. A tricuspid valve anatomy is examined using a blunt nerve hook and the atrialized right ventricle is evaluated. The first incision is made in the anterior leaflet at 12 o'clock position. The incision is few millimeters away from the true annulus. Diagram demonstrates the scissors approach with some adherence of leaflet tissue to the underlying myocardium. Surgical delamination. Incise all fibrous and muscular attachments between the body of the leaflet and the right ventricular myocardium. A 5-ohm monofilament stay suture is placed in the leaflet tissue at approximately 2 o'clock position. Then examine the anatomy of the leaflet from both sides, whether the leading edge is attached directly to the myocardium. uh, This has been referred to as linear attachment. When a linear attachment is present, it is treated by making fenestrations in the skeletal leaflets, the equivalent of making natural neocordae. All fibrous and muscular attachment to the body of the underside of leaflet are incised as shown with the scissors. The dotted triangle represents atrialized right ventricle in the image. After the anterior and inferior and septal leaflets have been completely mobilized, the cut edge of the inferior leaflet is rotated clockwise to meet the proximal edge that has been prepared of the septal leaflet. The two are approximated with interrupted 6-ohm monofilament sutures, completing the cone reconstruction. This results in 360 degree of valve leaflet tissue that will make up the new tricuspid valve orifice. A trialized right ventricle is examined to determine if plication is necessary. Note the position of the right coronary artery in the true tricuspid valve annulus and keep in mind that there are acute marginal branches of the right coronary artery that can be compromised with plication. Internal plication of the atrialized right ventricle is done with monofilament 5O suture is utilized and the suture is begun distally, i.e. closest to the apex of the right ventricle. It is important to frequently examine the outside of the inferior wall of right ventricle to ensure that inadvertent compromise of branches of right coronary artery is avoided. The suture line is advanced towards the base of the heart, i.e. towards the atrioventricular groove. It is important for this suture line to stop approximately 1 centimeter before reaching the atrioventricular groove to avoid injury to or distortion of the right coronary artery. After plication or resection is completed, the newly constructed tricuspid valve is then reattached to the level of the true tricuspid annulus. Because the neotricuspid valve will have an orifice that is smaller than the original dilated atrioventricular junction, a plication of the inferior annulus is necessary to meet the size of the neotricuspid valve. The completed cone reconstruction of the tricuspid valve. Saline is injected via bulb syringe into the right ventricle to examine competency of the tricuspid valve. Any residual fenestrations or areas of leak are repaired as needed. This represents an anatomic repair because there is 360 degrees of tricuspid leaflet tissue that surrounds the orifice of the tricuspid valve, and it is anchored at the level of the normal right atrioventricular junction. Extreme forms of thin dilated and redundant right atrium is excised. Relative contraindications for cone repair are age more than 50 years, moderate pulmonary hypertension, significant left ventricular dysfunction, ejection fraction of less than 30%, complete failure of delamination of septal and posterior leaflets with poor delamination of anterior leaflet less than 50%, severe right ventricular enlargement, severe tricuspid annular dilatation. So these are the statistics of Da Silva et al. From November 1993 through August 2005, 40 consecutive patients with Ebstein's anomaly. There was one hospital death and one late death. Early postoperative echograms have shown good right ventricular morphology and reduction in tricuspid regurgitation grade. After mean follow-up of 4 years, the functional class improved. And there was neither AV block nor tricuspid valve replacement at any time. 1.5 ventricle repair. The bidirectional cavopulmonary anastomosis does two important things in the setting of Ebstein's anomaly. First, it reduces venous return to the enlarged dysfunctional right ventricle by approximately one third. Second, it provides sufficient preload to the left ventricle to sustain adequate systemic perfusion when right-sided output is low. Surgeons usually prefer it if the left ventricular end diastolic pressure is less than 12 millimeters of mercury and the transpulmonary gradient is less than 10 mm of mercury and the mean pulmonary artery pressure is less than 16 millimeters of mercury before considering a bidirectional cavopulmonary anastomosis. Indications for bidirectional cavopulmonary anastomosis include severe right ventricular enlargement or dysfunction, squashed LV, D-shaped LV, moderate degree of tricuspid stenosis, mean gradient more than 6 millimeters of mercury as a result of reduction of the valve orifice after repair. Valve orifice area after repair. Right atrium to left atrial pressure ratio greater than 1.5 indicates poor RV function. Preoperative cyanosis at rest or with exercise. Sebening et al. Pioneered an annuloplasty technique that involves narrowing the tricuspid valve orifice with a pledgeted mattress suture placed from the center of the anatomic annulus of the anterior leaflet to the native annulus on the opposite side, creating a double valve orifice. The posterior annulus can be closed with additional pledgeted sutures or left open as needed to produce a competent tricuspid valve. So, another modification of the Danielson approach is play where it lies approach to the repair of Ebstein's anomaly. This operation involves limited plication of the tricuspid valve. Points A and B in the diagram are approximated with one or two mattress sutures at the level of the native valve, not to the level of true tricuspid annulus. This results in approximating apical aspects of septal and anterior leaflets, effectively creating a bicuspid valve. Uh, Outcomes of operations for 539 patients in Ebstein's anomaly at Mayo Clinic. From 1972 to 2006, 539 patients were operated for Ebstein's anomaly at Mayo Clinic. Mean age was 24. Tricuspid repair was done in 182 patients. Tricuspid replacement was done in 337 patients. 30-day mortality is 5.9%. It is 2.1% after 2001. 10-year survival is 84%. 20-year survival is 72%. NH data, in the last 3 years, 2000, total of 44 patients have been operated. In 2022, 15 patients. Of those, 12 patients underwent cone plus BDG, and there was no mortality. In 2023, 19 patients were operated, 13 required only cone repair, and 6 required cone plus bidirectional glantion. There was one in hospital mortality. In 2024, 10 patients were operated, 8 underwent cone repair, and 2 patients required cone plus bidirectional gland, and there was one in hospital mortality. From 2011 till date, 301 patients underwent cone repair. Early rate is 5.6%, 17 patients. In the last 3 years, 44 patients were operated, 2 patients had died in hospital, and 2 patients required ECMO support. Both the patients were successfully discharged. Thank you.
Yeah, thank you, Yogendra. I have a few comments to make. Uh, Honestly, I don't have much experience about management of Epstein's, but you should have highlighted a little bit about. There are few classical features of Epstein's. One is the history. The patient develops cyanosis in the early stage, then they recover and they're sort of become almost normal, and then again in the later stages they redevelop their cyanosis. You must understand the pathophysiology of this phenomenon. Do you know why it happens?
Yes, sir.
So that is about the classical history. Then when you see a child with a huge heart and severe TR, Epstein's is the first diagnosis that is made. So that is one thing that you have to know. And then secondly, you described very many different techniques. It was more or less sort of a theoretical, description with a monotonic presentation. We could not understand exactly what are the various features that you are trying to tell us. Third, I want to know, what do you mean by delamination? Do you understand what exactly delamination is and how it is done, and why is it is done? Do you know that? Have you seen an Epstein's operation?
Yes, sir, I understand.
Yeah. Okay. Tell me
Yes,
what
sir,
what
I
do
have
you,
seen
what
2 cases.
exactly do you do in delamination?
Sir, during delamination, first the anterior leaflet is detached from the annulus, and then underlying muscle and fibrous tissue attached to the lower under surface, the right ventricular surface, is
Yeah.
removed. I mean,
The
separated from the
anterior
valve.
leaflet is generally plastered to the RV, and then you have to detach that.
Yes, sir.
Then, of course, you talked about the choice of the procedure. You should understand. See, there are so many techniques. I don't think you should remember all of them. So you have to learn what to use, what technique to use in which situation. Maybe use about three or four techniques, and then you must be adept at that, and then a complete understanding of that. And third, lastly, you did not touch anything about tricuspid valve replacement. There are certain technical details of implanting a tricuspid valve in an Epstein's case. I'm not very sure about that. Perhaps Jairaj sir will be able to tell you that. So you must know that what are the implications or what are the indications for tricuspid valve replacement, as well as the technical details. So how is it different from a normal tricuspid valve
Okay, sir.
implantation? Okay. And lastly, I think it's a quite an impressive statistics from NH itself. And then this is quite a good number, and I think it requires publication. I'm not sure whether people have published these things um, in the literature. Are you aware of that? Are there any publications from NH on
No,
this
sir.
aspect? I
No,
think
sir.
Chinnaswamy Reddy had done some publication earlier. I'm not too sure. So, any comments, sir?
As you said, I am also not an expert in this. But only things, few things are very important. Krishna said, is classically said a bimodal presentation. That's the first thing when you say about Ebstein's. Uh, it's in the first few weeks, they present with severe cyanosis and left heart failure. The severe cyanosis is because of the increased pulmonary vascular resistance of the newborn. So much so, the the left the right to left shunt to an ASD is increased, so that gives the severe cyanosis. And the other classical expression, like a bimodal presentation, is the crashed left ventricle, like a pancake. That's a classical description because the right atrium is enlarged uh, and the atrialized portion of the right ventricle is massively enlarged. There's severe tricuspid regurgitation, and sometimes the very much enlarged anterior reflex can even cause obstruction to the right ventricular outflow tract. Because of these reasons, the bimodal presentation in the few weeks after birth, the present with severe cyanosis and left heart failure. Then, as the pulmonary vascular resistance decreases, the right to left shunt becomes less, and they seem to have some improvement. And then they may present in the second decade, first or second decade. That's why it's classically known as a bimodal presentation. The other thing is the GO score, the Great Ormond Street echocardiography. It's that pronunciation of that is Selmer, John Selmer, Celmerger. It's not known as Selmerger. It's a Polish Jew migrated to London and then came to Sydney Hospital. I used to meet him in Sydney Children's Hospital. His name is John Selmer. He's the one who described the most important thing, when you see an X-ray in Ebstein's, this is one of the conditions where the maximum transverse diameter is perfect. That's because of the enlarged right atrium, enlarged atrial portion of the right ventricle. So the score is, you can describe it detailing. The score is depending on the enlarged right atrium plus enlarged atrialized portion of the right ventricle, which is, is to the dimensions of the true right ventricle, true left atrium, and the left ventricle. These three. So these three together on one side, the right atrium and the atrialized portion of the right ventricle on the other side. This is the ratio. If it is less than 0.5, very good. Most of them survive. You said 8%. Some people, the mortality is 8%. Some people say 0%. The second is when it is between 0.5 and 1 and 1.5. Ever 1.5 is the ratio. Almost 100% fatality is there. In the second type, sometimes it's describes acyanotic and cyanotic. The mortality depends on these things on the GOS score. The other thing should have described that, the natural history that the Incidence of this condition is very rare, less than 1%. You said 0.3 to 0.8%, that's correct. But generally we say less than 1%. And those who present early in the first few months, the mortality in the first year is about 20 to 30%. And those who are not so sick, mortality is about uh, another 10%, about 30% by age of 10. So it depends on, and then the operations are either palliative, first medical, you said that you have described completely, and then palliative. Palliative may be one, enlargement of the ASD, because it's only PFO. There's a problem, the blood circulating to the left side of the heart. So enlargement of the uh, ASD, then stance operation where is either complete closure of the tricuspid valve or fenestrated closure, or then you have to decide whether, depending on your echocardiography, whether this is suitable for a two ventricular repair or a one ventricular repair. If it's a single ventricular repair, then usually you can do uh, a BT shunt, a stance procedure plus BT shunt, or the Sana procedure where part of the right ventricle is excised also, and the BT shunt. BT shunt in the first few months, and after 6 months you can do a BDG, and then later on do a Fontan. So you have to decide whether you're going to do a single ventricle or a two ventricle correction. And the other thing is, describe a little more because the two classical operations for the Mayo Clinic by Gordon Danielson, that were the most popular sometimes, and Carpentier. Both of them. The other thing is that most of the time, the Ebstein's anomaly, the septal leaflet is displaced down about 90, in 90% of the cases, the posterior also in about 50% of the cases. Then you said about the first the Danielson's operation and the Carpentier's operation. In Daniel's operation, the mobilization is done and plication of the atrialized ventricle is in a transverse fashion, and then the septal and the posterior thing is lifted to the true uh, AV groove level by projected sutures and plication sutures of the atrialized portion. How do you know the true analysis? Because of the presence of the right coronary. That's the indication of to that level. And then do a annuloplasty by one stitch or two stitches. The Mayo Clinic or Gordon Daniels never use a ring. Up until it's a vertical plication, and then a ring is always used. Actually, it's shaved. Then the best is cone operation. Cone operation is the it starts a little away from the septal and anterior leaflet by disconnecting the anterior leaflet and delamination, as you said, then continues the delamination of the posterior leaflet, delamination of the septal leaflet, and then rotate completely so that that point comes to the original incision. Original incision, as I said, is little away from the anterior and septal leaflet. So the whole anterior leaflet is now used for uh, competency of the tricuspid valve. This is what I know about these things. And then the Krishna said about the tricuspid replacement. Nowadays, people don't do much of tricuspid replacement in such cases because it's a disastrous operation. And in the statistics you gave for Mayo Clinic, out of 539, 330 valve replacement. That's not an acceptable thing. Nobody does those things. And Krishna mentions about technique of tricuspid valve replacement. It's usually a supracoronary. It's a way to avoid the bundle. That means the valve is placed above the coronary, so that coronary sinus now is into the right ventricle. Not, that's not in the right atrium. That's a technique of tricuspid valve replacement. And in cases where it's not adequate, that's why the people had a BDG. The essential condition of doing a BDG is that the mean pulmonary artery pressure should be less than 16 millimeters of mercury. Otherwise, no BDG will work, They'll get a, because the superior vena cava blood cannot go and then they get edema and all sorts of problems. So you have to select which cases you do ADG and which cases you do only cone procedure. And cone procedure is probably the best. And I think statistics is about 5% mortality, and Da Silva from Sao Paulo is 2.5%. And ours also is a good research paper. I think you should publish that again. Very large number and good research. Okay. Any doubt?
Yes,
So
somebody has to work on this. Maybe, use this as a thesis topic and then do this. It's quite an impressive number.
Yeah. Remember the two words I said, bimodal presentation and the scratching of the left ventricle because of the enlarged atrial portion of the right ventricle and right atrium curves like a pancake. So the LV function becomes less. So that leads to increased LA pressure, and that also leads to increased pulmonary pressure and pulmonary vascular disease in such cases. And saying a chest X-ray, it is one of the cardiac conditions where the transverse diameter is almost 90% or even 100%. Okay.
I'm a bit disappointed that none of the pediatric surgeons, practicing pediatric surgeons, take part in these teaching sessions. At least there are a number of fellows. So one of them should come at least, so that we know what is being practiced nowadays. I think it is your onus is on you people that you should insist that they should come and educate you guys. If you just say, sir, please come and things like that, and one this thing, none of them are interested also. So if you insist on that, sir, you have to come and things like that. Someone might this thing might be able to join. I mean, it's ridiculous that none of them take part of in any of the teaching sessions. It's pathetic.
Even guys who are in pediatric cardiac surgery trained by us, there are many of them, at least they can come.
Yeah, there are fellows there. There are other people there. At least some of them should take part in these things. Anyway, you can take the horse to water. Okay, thank you, Yogendra.
Thank you.
Thank you. Thanks. Thank you.
Thank you, sir.
Bye.